Thank you very much for your invitation. I will talk tonight about the finger deformities in rheumatoid arthritis. And we have the Boutonniere deformity, which is a flexion of the PAP joint and extension of the DIP. Swan neck deformity, which is the reverse, extension of the PAP and flexion of the DIP. Mallet finger deformity, which is only deformity of the distal joint, which is flexed, lost in the extension. And finally, the claw deformity, which is not typical from rheumatoid arthritis, but it's another type of deformity in the fingers. But you will see that we see when there is a flexion contracture of the PAP joint or intrinsic muscle paralysis. So we'll start with the boutonniere, followed by swan neck, and then the mallet finger. The boutonniere, I would like to close this thing here, or move it. Yeah, okay, now. The boutonniere deformity, it's an alteration of the extensor apparatus right here. This is the proximal phalanx, the distal phalanx in red, the extensor apparatus in yellow. This is the central slip and the lateral slip. And these are some intertendinous connections between the central slip and the lateral slip. Here we have the transverse retinacular ligament that prevents the lateral band to go excessively dorsal, the triangular ligament that prevents the lateral band to go excessively anterior, and this is the oblique retinacular ligament. As you can see, the extensor, the central slip, it's always on top of the condyles, on top of the joint. But the lateral band has to move dorsal and volar during joint flexion. In the boutonniere deformity, it's a lesion of the central slip and the intertendinous connections. So the lateral band stays normal, and with time, the transverse retinacular ligament shortens, remodels in a shortened position, and the triangular ligament elongates, allowing the lateral band to fall below the axis of rotation of the PAP joints. And it's called the boutonniere deformity because the condyles of the proximal phalanx, this is the PAP joint viewed laterally of this finger right here on the top. And the condyles of the proximal phalanx, they protrude in between the both lateral bands, like a hole in a buttonhole. That's why it's called boutonniere. The extensor tendon needs further distal displacement to allow flexion of the DIP joint here. So the lateral bands, in order to flex the DIP joint, they have to displace volar to the axis of rotation. This is the central slip, this is the central slip, and when we flex the joint, the lateral band falls below the axis of rotation. In these structures right here, they change position. So seen from the top, here's the extensor tendon, central slip, middle phalanx, lateral bands. This is the distal extensor tendon. And when we flex the joint a little bit, the lateral bands start moving to the sides. And when we move the joint into full flexion, then the lateral bands are completely at the sides of the condyles of the proximal phalanx. The central slip always stays in the middle. And that's why it stays in the middle and has this thickening right here, which is called the dorsal plate, which morphologically it's like a patella tendon, a bone, and histologically it's fibrocartilage, because the tendon it's not designed to hold to support pressure, but just tension. And that's why the condyles of the proximal phalanx are more marked in flexion than in extension. Extension is more flat, but then in flexion, they provide stability to the dorsal plate. So the extensor tendon, the central slip always stays at the top of the joint. Now, here, a lateral view, a photograph. This is proximal, this is distal. In extension, the lateral bands are dorsal to the axis of rotation of the PAP joint. And as we flex the joint, the central slip always remains at the center of the top of the joint. But the lateral bands, they move to the sides in order to make a shorter distance from the proximal phalanx to the distal phalanx. And for this reason, the condyles of the proximal phalanx, they are oblique, like this, to allow the lateral bands to go from dorsal to volar, from dorsal to volar. And only in cases of Swan neck deformity, the lateral bands may be too dorsal in one or both condyles. And then we can have a snapping of the finger when it goes from hyperextension to flexion. So this is a drawing of this interconnective tissue between the central slip and the lateral bands that should allow the central slip to go distally and the lateral bands to go also distally, but move to the sides. So this distance widens when the finger flexes. In normal circumstances, there is a balanced flexion of both interphalangeal joints. So when the proximal interphalangeal joint is in extension, the distal one is in extension. When the PAP joint flexes a little bit, the DAP joint flexes a little bit. And when the PAP joint flexes more, the DAP joint flexes more. But it's always a balance between the position of the two joints. In a boutonniere deformity is the consequence of a lesion of the extensor apparatus. So which means that there is a flexion of the PAP joint and extension of the DAP joint. Doesn't need to be a hyperextension like here. Just if we have flexion here and normal extension here, this is already a beginning of a boutonniere deformity. Because if the PAP joint is flexed, the DAP joint should be flexed also. It's an MRI of a finger, you can see here, swollen finger, with a synovitis of the PAP joint in this area right here. And you can see soft tissue edema and a synovitis of the PAP joint, dorsal and volar. This is the retrocondylar process of the proximal phalanx. This is the subchondral bone of the head of the proximal phalanx, and this is the base of the middle phalanx. As you can see, the extensor tendon, the central slip, this is a sagittal cut. We can see it inserting into the middle phalanx. Here will be the flexor tendons. So here we can see that the central slip is intact. Here on top left, there is a transverse section on MRI of the proximal phalanx, distal, behind the condyles, proximal to the condyles. You can see the central slip, one lateral band, the other lateral band, and this is the connective tissue that we were talking before. And if we have a synovitis of this joint, we can see at first that the central slip will be intact. And here it's also intact, pushed towards one side, but it's intact. This is one lateral band, and here is the other lateral band. And here in the intraoperative photograph, we can see that the central slip is more or less intact, and the synovitis from the PAP joint, it's protruding between the central slip and the lateral bands. So the first thing will be a herniation, a rupture, or a disruption of the connective tissue holding the central slip and the lateral bands together. And now from the academic point of view, the boutonniere deformity has been classified in 3 stages. First stage is a correctable deformity. Second stage is non-correctable, which means that we have a stiff joint because of long-standing loss of extension of the PAP joint. In the third stage is cases of Boutonniere deformity with joint destruction. Not very common, because as the joint loses mobility, then the synovitis disappears, and with the passing of time, the synovitis will be completely cured if the joint doesn't move. If we want to see if it's correctable or non-correctable, we shouldn't do it this way, pushing the distal joint, the distal phalanx dorsally. We should do pushing the proximal phalanx dorsally and the proximal phalanx volarly. So we can see if this joint is correctable. And also the most important thing is that we want to see if this joint corrects or continues in hyperextension. If it continues in hyperextension or even increases the extension, when you extend the PAP joint, it means that the lateral band is dislocated volarly and the transverse retinacular ligament prevents to go dorsally and pulls the DAP joint in more extension. So this, if you have this circumstance here, that correcting the PAP joint, the DAP joint loses hyperextension, like here, this has a better prognosis for a surgical repair. What can we do? There are several techniques to repair the extensor apparatus right here. And every time you see many techniques that they are being described to solve one single problem, it means that none of them is much better than the others. But we'll see, but from the historical point of view, we'll see some of them. The one on the left, described by Nichols, all of them, they release the lateral bands, cutting the transverse retinacular ligament, and placating the triangular ligament. This is basic, but what to do with the central slip? Nichols used a tendon graft through the base of the middle phalanx to reconstruct the central slip. Adrian Flatt he had a very interesting technique, which used a palmaris longus tendon graft here, along with some antebrachial fascia. In the antebrachial fascia, used it to dorsalize the lateral bands. So he wrapped the antebrachial fascia along on the volar side of the lateral bands to bring them together up to the dorsum of the joint. What he did is to remove a flap of the proximal part of the central slip to reconstruct the broken one at the dorsum of the joint. Matthew described a good technique, well, interesting, in the sense that cut both lateral bands. He didn't do anything with the central slip. In the shorter lateral band, proximally, he used it to extend the PAP joint. In the longer lateral band, proximally, he sutured to the longer lateral band distally to release the hyperextension of the DAP joint. This was quite a clever, I don't have any experience, but it's quite a clever technique. Bill Littler, on the other hand, he forgot about the DAP joint, didn't do anything with the transverse retinacular ligament, and concentrated all the surgical efforts in regain extension or provide extension of the PAP joint. And he did it by using both lateral bands attached to the base of the proximal phalanx. Personally, I prefer to do an anatomical reconstruction if it's possible, which means release the transverse retinacular ligament in order to dorsalize the lateral bands, placate the triangular ligament in order to keep the lateral bands in the dorsum, and also do a plication, if possible, of the central slip. Here we have quite a severe boutonniere deformity, which is not fully correctable, but it's quite acceptable for a soft tissue repair. The joint is normal by clinically and by X-ray examination. And here we can see the case that I showed before and we can see here that the lateral bands are here well below the axis of rotation of the PAP joint. This is seen from the dorsum of the proximal phalanx. We can see one lateral band and the other lateral band here. Here we can see one lateral band and the other lateral band. This is seen from the top. These are the condyles of the proximal phalanx. So first we do an elliptical excision of the central slit. Here we can see, after we did the elliptical excision of the central slit, we can see the condyles of the proximal phalanx. And we can see it here also. Then we cut the transverse retinacular ligament of Landsmeer. We do an incision here, and here the lateral bands. This is the transverse retinacular ligament, and here is the elliptical excision of the central slit. So now we have to, the next thing we have to do is to bring the lateral bands dorsally, approximate the central slit that we have done an elliptical excision before. Here we have a lateral band which is a little bit redundant, and the lateral band probably not as much redundant. But the problem is that the Boutonniere deformities, well, obviously, we do a repair. We do a repair, an end-to-end repair of the central slit, and we do application of the lateral bands. The problem is that Boutonniere deformities present a dilemma for the surgeon. The patient comes to the surgeon hoping that he's a god and he will be able to fix anything, but the Boutonniere deformity, it's very difficult to repair. It also has the disadvantage that severe deformities are very difficult to treat, and you may well not even attempt to treat them. And the other problem is that the mild deformities can be made worse by the surgery. And why? Because the patient prefers to lose the last 40 degrees of extension of the finger, of the PAP joint, than the last 40 degrees of flexion, because the finger will have more use and it will be less disabled if he can flex completely, even though loses some extension. Anyway, the aims of treatment are improve active PAP joint extension and correct the PAP joint hyperextension. Now we'll see all the techniques to improve active PAP joint extension. First, the joint should be passively extended because we cannot do both things. Joint release, anterior joint release, and an extensor tendon repair at the same time. The finger will be too swollen. It will become a stiff finger in extension. So the patient will be very unhappy. Because with the passage of time, the PAP joint will become stiff in flexion. From remodeling of the transverse retinacular ligament in a shortened position, the oblique retinacular ligament that goes from the just distal to the A2 pulley, originating at the bone and below the transverse retinacular ligament, to the extensor apparatus, the volar capsule of the joint, which we don't see here, the flexor tendon sheath, and the skin. So we can see cases like these. They are not correctable, and those are impossible to be treated, because we have to have a full passive extension of the joint. So it is so important to prevent this end stage of the deformity. We should do a PAP joint synovectomy as soon as we can. There's some things that are not so important in rheumatoid arthritis, like carpal tunnel syndrome release, because with time it will go away. Extensor tendon synovitis, or many other mainly any tendon synovitis, but the PAP joint synovitis, it's an emergency, because if you let it go, you will have a tendon joint destruction, but mainly a tendon destruction, which will be very difficult to treat. So if you see a a PAP joint synovitis, you should immobilize it with a splint and leave it at rest so the synovitis may disappear and prevent tendon rupture. And if not, then you will have a destroyed PAP joint. And if you have a destroyed PAP joint, what can you do? An arthroplasty or an arthrodesis? An arthroplasty, it's not a good idea. An arthrodesis, probably it's a better idea, mainly in cases like this, that you have rheumatoid nodules. You can see the condyles of the proximal phalange here or here. It means that there is absolutely no extensor apparatus on top of the finger, or there are skin lesions like psoriasis, like here, in this finger or this finger. Sometimes severe boutonniere deformities are very difficult to treat. And an arthrodesis is the best choice. An arthrodesis of the MP joints, like here, we have an arthrodesis of the MP joints here and here. It's very disabling. And that's why we never do an arthrodesis of an MP joint of any finger under hardly any circumstances, because the arch of movement for grasping objects of the finger, it's very slow. It's very small. It's only this. Only very fine objects we will be able to grab with the flexion of the PAP and DAP joints. On the other side, if we fuse a PAP joint, if the MP joint is normal, the useful arc for finger flexion will be much bigger. You can hold a glass and many other objects with good MP joints, but a fused PAP joint. The problem is when only one finger is involved, like in this case here, because it's aesthetically is not very nice to fuse just one finger in extension like this, or flexion, or if there is joint destruction, like in this case. This is a rheumatoid patient, the ring finger. She was a young lady, remember her very well. She insisted that she wanted to regain flexion or, well, mobility of the PAP joint. I told her that we will try, but the only way we could do it is placing an implant, an arthroplasty, because the joint was destroyed. So I put an implant of the PAP joint. I repaired the extension tendon. I put the plaster, then later on a dorsal splint to maintain it more or less in extension. And I told her, listen, we cannot have it like this for a long period of time. You should really wear it for about 5 weeks or 6 weeks, because an extensor tendon is a very thin structure, and the flexor tendons are very powerful, and the repair will break. So we'll try to keep it in extension as much as we can. But if you want to regain flexion, you can do it slowly, but every time you gain flexion, be sure that you regain the extension. You can gain flexion, but regain the extension. If you only gain flexion, it means that you got a disruption of the extensor apparatus, and you shouldn't force the finger again into flexion. But the problem is that all the patients, they want the fingers to get flexed. And this is what happened to this lady. She got again 45 degrees loss of extension of the PAP joint, because she wanted to regain flexion, which is quite normal or understandable from her job or whatever, but not for the repair of the extensor tendon. That should be immobilized for about 5 weeks, if you can, in all the cases that we mentioned before, to do repairs of the extensor apparatus. So severe and fixed boutonniere deformities are very difficult to treat, and you wouldn't like to see them. In arthrodesis, it's a good alternative when all fingers are involved and the MP joints are normal, obviously. This is a case in which all fingers are fused in moderate flexion, and the function of the hand is quite well tolerated. Correcting the DAP joint extension or hyperextension, it's easier than improving PAP joint extension. So that's I think we should be doing this in all the patients with a Boutonniere deformity. And we can do this by a tenotomy of the distal extensor tendon. There's several techniques described. One, it's cutting the extensor tendon. This is the distal phalanx, distal phalanx, distal phalanx. Cutting the extensor tendon proximal to the insertion of the oblique retinacular ligament. Because people, doctors or surgeons are afraid that we might create a mallet finger deformity. Another technique is to do a VY advancement tenotomy of the extensor tendon, so the patient will adjust the length that he desires to the shortened extensor tendon, or do a step division of both lateral bends. Preferably, myself, I recommend to do complete division of the extensor tendon. This is too complicated and you will never get a mallet finger deformity. And if you get a mallet finger deformity in a boutonniere, it's even better for the looks of the finger. So the PAP joint will be slightly flexed and the DAP joint will be also slightly flexed. But it's not only the tendon. The dorsal skin gets remodeled in a shortened position in a long-standing boutonnieres. So we can just do a simple incision that we will not gain any length. We may get a length, not if it's done a longitudinal incision, but we can gain some length if we do oblique or transverse. But with time, the skin will reapproximate, will heal, and we'll have the DAP joint again in extension, which is something that we didn't want. So what can we do then? We can do a Z-plasty lengthening. A Z-plasty, we cannot do a traditional Z-plasty because we don't have enough skin from the sides to provide the flaps to move and gain extension. We can do a VY advancement, but the same problem. We don't have enough skin to close this gap here. And preferably, myself, if you have long, very severe and boutonniere deformities with a lot of extension of the DAP joint, I prefer to use a full thickness skin graft. I do have a curved incision with creating a distal flap covering the joint, and then it replace the space with a skin flap. And here is schematically how it's done. This is the proximal middle phalanx, distal extensor tendon, oblique retinacular ligament, and the dorsal capsule. The skin incision is done here in a curve, making a skin flap right here, proximal to the joint, not to leave the joint exposed. Then the extensor tendon is cut completely, transversely, and if possible, if necessary, the dorsal capsule, it's cut, and if not, it's manipulated into flexion. And by doing so, we'll make a gap between both ends of the extensor tendon, and we will have a gap in the skin here that we will cover with a full thickness skin graft. Here an example of a very severe boutonniere deformity with hyperextension of the DAP joint, and as you can see, the dorsal skin is quite short. This is a maximum flexion of the DAP joint, and in this case, the redundant skin that is removed here The joint was fused, obviously. This is the entrance of a K-wire. Here we can see the entrance of another K-wire. And then the skin obtained from the dorsum of the PAP joint, it's used to graft the dorsum of the DAP joint. And this, I think, is the best way to treat a very severe boutonniere deformity. Well, now let's go into swan neck deformities. First, we'll look at the etiopathogenesis, because it's not like a boutonniere deformity, which is quite clear that it's secondary to synovitis of the PAP joint. It's not a tendon problem, it's a joint problem, really, although the consequence is a tendon problem. But the pathology is a joint problem. Here, the pathogenesis, there are many theories, because it's not very clear. And that's why there are described even 8 causes of swan neck deformity: carpal collapse, MP joint synovitis, spasticity or retraction of intrinsic muscles, PAP joint synovitis. All these are fiction, and we'll discuss them now, and we'll try to convince you. In fact, rupture flexor digitorum superficialis will contribute, but will not in itself, will not cause a swan neck. Mallet finger deformity will also contribute, but will not cause a swan neck deformity. And finally, the only cause of a swan neck deformity, from my point of view, is the synovitis of the flexor tendons in the finger. Let's look at the carpal collapse first. This is a theory that has been popular for a few years, because they say that with the carpal collapse that we see in a rheumatoid wrist, we have a relative lengthening of flexor tendons, causing an extrinsic minus deformity of the fingers, and therefore a swan neck deformity. But if we have fracture of the distal radius with severe shortening of the radius or proximal row carpectomy, this is equivalent to a carpal collapse in a rheumatoid arthritis. It's even worse. We can have a much larger deformity, shortening of the bone in extrinsic minus deformity of the flexor tendons, and never will see a swan neck deformity after fracture distal end of the radius or proximal row carpectomy, even though those are things that happen suddenly, not like in the rheumatoid arthritis, where the carpal collapse appears very slowly with time, and sometimes taking even months or years to occur. MP joint synovitis, they say it's because the MP joint, the synovitis, causes irritation of the intrinsic muscles. But intrinsic MP joint synovitis, we see it many times, sometimes, like in this case, with a swan neck deformity, but other times with boutonniere deformities. It all depends on what we have besides the MP joint synovitis. If we have a synovitis of the flexor tendons, or we have a synovitis of the PAP joint. They say that when there is a dislocation, a disease of the MP joint with synovitis, there is a volar displacement and proximal displacement of the proximal phalanx, and this will tighten the intrinsic muscles. But if you look at the anatomy, you will see when this thing happens, the origin and the insertion of the intrinsics into the base of the proximal phalanx will be shorter in this position than in the normal position. So we don't think a synovitis here will cause a swan neck deformity. Spasticity, like here, or retraction of intrinsic muscles from fibrosis, will never cause a swan neck deformity unless the volar capsule of the finger is elongated. If the volar capsule is not elongated, which is the most common thing in normal people, you will never see a swan neck deformity. What is true is that In swan neck deformities, there is a shortening of the intrinsic muscles. This is no doubt about. But, and here we can see it in these pictures, swan neck deformity. The MP joint is flexed and the PAP joint is extended because the intrinsic muscle is shortened. But this is not due to spasticity of the intrinsics. This is secondary to shortening of the sarcomere of the muscle, of the intrinsics. And this is not pathology, this is physiology. If we have the origin and the insertion of the muscle closer for a long period of time, the muscle will remodel in a shortened position. So we see, in swan neck deformities, we see that there is a shortening of the intrinsic muscles, but this is not the pathology, this is the physiology. Synovitis of the PAP joints, they say that can cause a swan neck deformity because it weakens the volar capsule, but this is not true. We all know that synovitis of the PAP joints will weaken the dorsal capsule and will cause a boutonniere deformity. Rupture of the sublemmis tendon. It will contribute to the deformity, and rupture of sublemmis tendons are relatively common in patients with rheumatoid arthritis. The problem is we don't examine them. We saw the big deformity in the fingers, but we examine the fingers individually by holding the extensor, the flexor profundus in extension, and as the patient to flex the PAP joint, he will not be able to do it in many cases because some of them, they have a rupture of the profunda, of the sublemmis tendon. In the mallet finger deformity, will contribute to the deformity of a swan neck deformity. This is well known in patients that they have a mallet finger deformity from trauma, in young girls that they have a lax PAP joint, that they will develop a slight swan neck deformity. Flexor tendon synovitis, it's relatively common in rheumatoid patients. Rheumatoid patients, they have synovitis of the extensor tendons, only here, in the osteofibrous tunnel on top of the radius. All the other pathology of the extensor apparatus, it will not be secondary to a tendon synovitis because there is no synovitis of the tendons here, will be secondary to underlying joint synovitis. But flexor tendon synovitis is quite common. We can see it in the carpal tunnel, difficult to diagnose clinically, and we can see it in the flexor tendon sheath, a little bit easier to diagnose. Inside the carpal tunnel, we have an MRI in a longitudinal section, lunate, distal radius, capitate, middle finger metacarpal. Here we can see the flexor tendons, darker, and here all the synovitis, white. And here we can see in the cross section, radius, head of the ulnar, and this is the synovitis around the flexor tendons. And here we can see the median nerve compressed and to the periphery. But the symptoms will be compression of the median nerve. But usually in the past, they used to say, well, this is an emergency, and you should treat, release the median nerve compression because you will have a sensory loss, permanent sensory loss. But this is not really true. If you see patients, elderly ladies with rheumatoid arthritis, seldom any of them will have a carpal tunnel syndrome, and they never had surgery before. But if you ask them, lady, do you remember in the past if your fingers were numb during the night or early in the morning when waking up? Yes, doctor, but not anymore. Why? What happened? Because the same synovitis did the surgery for you, elongated the flexor retinaculum. So the median nerve compression was released. And the other thing that we can have is a flexor tendon rupture. And the flexor tendon rupture is not from synovitis. Most of the time it's usually from the scaphoid. the distal end of the scaphoid dislocates, flexes, and the distal end of the scaphoid wraps, causes friction with the flexor pollicis longus, which is the tendon that most commonly ruptures in rheumatoid arthritis, this tendon right here, but not from the synovitis. If it were from the synovitis, all the tendons will rupture at random, and usually it's the flexor digitorum profundus, the one that ruptures more frequently in cases of rheumatoid arthritis. And inside of the flexor tendon sheath, how we can make the diagnosis? Well, if the patient comes to you, doctor, I had difficulties in closing my fingers, mainly in the morning when I wake up. Then later on I can close them a little bit more, but this is as much as I can flex them. So I don't know what can be. Well, let me examine your hand, and then you can see that passively you can flex the fingers, which this means that the joints are normal, the PAP joints and the DAP joints, but they are adhesions of the flexor tendon. Well, synovitis, because the interphalangeal joints flex from contraction of the extrinsic flexor muscles. The MP joint can flex with intrinsics, but the IP, PAP, and DAP joints, they flex only by contraction of the extrinsic flexors. And if we have a synovitis of the flexor tendons inside the flexor tendon sheath, like shown here in this drawing, then the patient will have pain, and they will have decreased gliding of the flexor tendons, and he has to use some muscle to do the activities of the daily living. She has to prepare breakfast, get dressed, etc. And then what will she do? She will use the intrinsic muscles. Intrinsic muscles will be very helpful to her because she will flex the MP joints that we said before. They were very important for the function of the finger, and she will flex the MP joints without pain. The only problem is that the intrinsic muscles, besides flexing the MP joints, which will be helpful to her, they will hyperextend the PAP joint, causing a Swan neck deformity. So the flexor tendon synovitis in the finger will cause restricted finger flexion, like here, intrinsic muscle overuse, and with time, elongation of the volar capsule of the PAP joint, and then we'll have a Swan neck deformity. For a Swan neck deformity to be present, the following needs to occur at the PAP joint: elongation of the volar capsule, and an imbalance between extension and flexion forces, both things. Many patients with rheumatoid arthritis, they have this type of deformity. We can hyperextend the PAP joint, but it's, as I said before, there are things that the patients are not aware and the doctor does not examine it. And why flexor tendon synovitis will weaken the volar plate? We don't need to have a synovitis inside the joint to weaken the volar plate. We can have the synovitis right here. This is the middle phalanx. This is the condyles of the middle phalanx. This is the volar plate. This is the arcuate ligament. And these are the vincula to the flexor tendons, the vincula that comes from both digital arteries. In most of the synovitis, it's right here, in touch with the volar plate. And the volar plate here, painted in green, it will get elongated, and you can have a Swan neck deformity if the extensor tendons, pulled by the intrinsics, they place more force of extension into the joint. And another observation, any person who can hyperextend the PAP joint, and probably some of you can, you can reproduce a Swan neck deformity. This is a young girl with relaxed joints, that I could hyperextend the PAP joint about 25, 30 degrees. And here we can see the same girl at rest, and here creating a Swan neck deformity. And how did she do this? Because she did it because she had a lax volar plate, and she did it contracting by contraction of the intrinsic muscles. What the intrinsic muscles do? Flex the MP joints. MP joints here at rest in moderate flexion, and here are flexed and tightly flexed. And the PIP joints are in hyperextension in the lateral bands subluxed dorsally. And this is a normal person just by contraction of the intrinsic muscle. Another observation, if you do a PIP joint volar capsule resection in substitution of the flexor tendon sheath by a silicone rod to do a second stage flexor tendon repair, you can see an index finger. Here the condyles of the proximal phalanx. This is the base of the middle phalanx. This is the silicone rod. This is the one pulley reconstructed, the A2 pulley, a little bit distally, and another A2 pulley more proximal. And this is the one pulley that remained intact. And this is the silicone rod proximally. This patient, well, it's not exactly the same, but it's another patient. This patient had the surgery done in the index finger. He developed, it was a man, developed a swan neck deformity of the finger. You can see flexion of the MP joint, extension of the PAP, and flexion again of the DAP. And I asked him, close the fingers, and she closed the fingers, flex all the fingers, and this one caused a swan neck deformity, an extension of the PAP joint. He said, no, relax, don't do anything, and then you can flex the PAP joint. So he was flexing the finger with the intrinsics. And by contracting the intrinsic muscle, he could flex the finger, but extended the PAP joint. So a swan neck deformity, in summary, it's an intrinsic muscle overactivity and with time shortening, which flexes the MP joint and extends the PAP joint, and elongation of the volar plate. So both things, they had to occur at the same time. If one does not occur, you will never have a swan neck deformity, but you just need to have this, and all the other changes that we'll discuss for the treatment will be secondary changes. This is a patient that came to me with a mild synovitis of the flexor tendons of the fingers. He could not flex completely the fingers, and the worst one was the little finger. And I took the finger and I could flex it passively completely. So we told him, listen, you don't have any problem with the joint, that you don't, it's because the tendons, you have a synovitis or the flexor tendons, if they don't allow you to flex the joint freely. So I think you should have a joint, flexor tendon synovectomy. He said, well, doctor, let me think about it. He came sometime later with a fixed swan neck deformity. So this was a few months ago. And in the late final stages, the PAP joint will become stiff in extension, like here. This is a maximum extension of the fingers. The MP joints in all swan neck deformities, you will see that they are slightly flexed because the intrinsics are shortened. And this is the maximum flexion of the fingers. He can flex the fingers at the MP joint, but not at the PAP joint level. So to prevent a swan neck deformity, what should we do? Same as we said before, with a boutonniere deformity, we should do synovectomy of the PAP joint as soon as possible and not let it go. To prevent a swan neck deformity, we should also do a flexor tendon synovectomy, because we know that this will cause or produce with time a swan neck deformity. It should be done in all the fingers, because usually it's in all the fingers or most of them, but we should not do it in 2 fingers and then in the other two, because the flexor digitorum profundus acts as a unit, but some authors, they recommended to do it in 2 fingers because it's easier for the patient. The recovery and the surgery, it's very long and very time consuming. And also it should be done in the entire full length of the finger, from the just at the level of the DAP joint, a little bit proximally. You don't need to go to cross distally up to the palm of the hand. Then we should preserve the flexor tendon pulleys. This is not like a tenolysis after trauma, which is really, in my hands, one of the most difficult procedures to be done, to do a release of adhesions of a flexor tendon after a laceration, because there is a lot of scar tissue around the tendons. The tendon surface will be damaged, and the pulleys are very tight. In rheumatoid patients, the 2 pulleys usually are quite lax, and they allow you to work in between the tendon and the pulleys with the scissors or with the knife or whatever you want, and you can do a full tendon synovectomy. But not all the cases are so easy, because sometimes the synovitis, this is the flexor tendon, this is the finger, this is a hook around the flexor tendon, pulling it away, and you can see that sometimes the synovitis invades the flexor tendons. But please try not to remove the entire flexor digitorum sublimis tendon, as they have done sometimes in the past, because then the chances of getting a Swan neck deformity are greater. Please preserve 1/2. I should have preserved this half and remove only this half that is more involved. But try to preserve the sublimis tendon if it's not fractured. After the surgery, this is just sometime after surgery, about 3 or 4 weeks, you should put a plaster in the wrist if the wrist is painful, because you want the patient to have a painless wrist and stabilize in extension, because the patient will try to flex the fingers but will flex the wrist, because he will not be able to put the wrist in extension, thinking that with the wrist in extension it will be easier to flex the fingers. As you can see, the fingers, they have been quite swollen after the surgery, but it's really not very painful. The tenosynovectomy is not like a joint synovectomy. A joint synovectomy, the wrist or the MP joints or the PAP joints are more painful, but joint synovectomies, flexors or extensors are not very painful, and the patients can regain flexion in a short period of time. Now let's look at the classification of Swan neck deformities. This is also from the academical point of view, same as a boutonnieres. Boutonnieres, it's correctable, non-correctable, and joint destruction, but there are gradings. It's not 1, 2, and 3. And here's the same thing, there are not 4. But it gives a good idea of what is the underlying pathology. In the stage 1, the PAP joint is flexible in all positions, and I will explain this. In stage 2, the PAP joint is only flexible in certain positions. That's the way it has been described by Ed Nerbo. What this means is that the PAP joint here can be flexed even with MP joint extension. And here in the stage 2, it can be flexed only in MP joint with MP joint flexion. What's the difference? That there is it's a retraction or a shortening of the intrinsic muscles in the stage 2, because we have to flex the MP joint in order to release the intrinsic muscle and allow us to flex passively or actively the PAP joint. In stage 3, The PAP joint is not possible in any position of the MP joint. Even if the MP joint is in flexion, the PAP joint will not be able to flex. Why? Because we have a remodeling or stiffness, remodeling of the structures dorsal of the PAP joint. And finally, the final stage is a destruction of the PAP joint. So 4 stages in Swan neck and 2 stages in Boutonniere. Stage 1, the PAP joint can be actively flexed in all positions, regardless if it's in flexion or extension of the MP joint. What's the underlying pathology? Elongation of the volar plate, obviously, otherwise we will not have a swan neck deformity. It possibly snapping of the lateral bands, and that's the reason why the patient will come to doctor's consultation, because the lateral bands, when they become excessively dorsal at the level of the PAP joint, they will snap. They will, instead of following the shape of the condyles, they will fall abruptly from the top of the condyle to the sides of the PAP joint. In the treatment in stage 1, patients will like to have treatment done either for aesthetic reasons, because people don't like to have a zigzag deformities of the fingers, either a swan neck or a boutonniere, or mainly is to prevent the snapping of the lateral bands, because it's a little bit annoying when they put the finger in hyperextension, then they have a sudden snapping of the lateral band when falls below the axis of rotation of the PAP joint. So what can we do in those cases? In the stage 1, when the joint is completely active, has full active mobility, we can restrict the hyperextension of the PAP joint, so the patient doesn't bring it into hyperextension. We can fuse the DAP joint if a mallet finger is present, and with that we will solve the problem of the snapping of the lateral bands many times. And we can try it before with a small aluminum splint on top of the finger after correcting the mallet finger and asking the patient to flex the PAP joint, or we can do a release of the intrinsic muscle retraction. Methods to prevent PAP joint hyperextension. We can use a dermadesis. Dermadesis is to remove elliptical part of the skin in the volar part of the PAP joint. But this will stretch with time, and it's not really, it's worthless to do it. We can do a palmar plate shortening, too complicated. We can do lateral band translocation, like Zancoli described, lateral band transfer, like Bill Liller described, retinacular ligament reconstruction, intrinsic muscle release, or a tenodesis of the PAP joint with 1 or 2 slips of the flexor digitorum superficialis. Lateral band transfer, which is Little's technique, consists in getting 1 lateral band, freeing the lateral band from the extensor tendon, leaving it inserted distally, cutting it proximally at the proximal third of the proximal phalanx, and then bring it below the axis of rotation of the PAP joint. So we'll change the position of the lateral band from dorsal to volar to the axis of the PAP joint. This is an example. Metaxial incision of the finger, lateral band, dorsal to the PAP joint. The lateral band is cut proximally. This is distally, which is left intact. Then it's released from the rest of the extensor tendon. We pass a clamp underneath Grayson in Cleland's ligament, and then we pass the lateral band underneath Grayson in Cleland's ligament. And by doing so, we remove the lateral band from the dorsum, volar, and we suture it proximally at enough tension as to prevent extension of the PAP joint. Oblique retinacular ligament reconstruction. It's a Thompson technique. Who was a fellow with Bill Littler. He thought that it would be a good idea to correct the PAP joint extension and the DAP joint flexion with a tendon graft, more or less reconstructing an oblique retinacular ligament anatomical pathway, which is lower to the axis of rotation of the PAP joint and dorsal to the axis of rotation to the AP joint. I never used this technique. I think it's very complicated. And personally, to prevent extension of the PAP joint, I use a slip of the sublimis of the flexor tendons. This is a technique that has been done by other authors. Using one or both slips of the flexor digitorum superficialis, which is cut proximally, is left attached distally in the middle phalange, and then the proximal stump of the sublimis, it's sutured to the proximal phalange, which I think is too much surgery in the finger, and the finger that has problems with the gliding of the flexor tendons. You can suture it to the A2 pulley, or you can suture it to the A1 pulley. And personally, what I do is the same principle, that you get a flexion of the PAP joint with a trigger finger. If you get a trigger finger with the enlargement of the flexor digitorum sublimis at the entrance of the A1 pulley, you will not be able to extend the PAP joint. So in the same based on the same principle that you will get in a trigger finger, what I do is I do a small incision in the A1 pulley to be able to put a suture of one slip of the flexor digitorum superficialis. The other slip I leave it intact to do what the tendon has to do, which is flexing the PAP joint. You can put a dorsal splint or a plastic cast to prevent the hyperextension of the joints and allow flexion postoperatively of the PAP and DAP joints. This is an extension, and here is inflection. Stage 2. The PAP joint can only be flexed when the MP joint is flexed, which means that there is a shortening of the intrinsic muscles. Obviously, elongation of the volar plate, possible snapping of the lateral bands, but the intrinsic muscle shortening in stage 2. Treatment, same as before, plus intrinsic muscle release, because this is the main pathological situation. But if interphalangeal active, not passive, is limited, we should always do a release of flexor tendon adhesions, besides the intrinsic muscle release. Retraction of the intrinsic muscles. How will we know if there is a retraction? Well, placing the MP joint in extension here, placing the MP joint in extension. This is my finger holding it in extension. With my other hand, I try to flex the PAP joint, and I will see here is blanching of the skin, my skin and the skin of the patient, and because of the shortening of the intrinsic muscles, I will not be able to flex the PAP joint. But once I flex the MP joint and I release the intrinsic, then I will be able to flex the PAP joint, if not completely, a fair amount, much better than here. So I know there is a retraction of the intrinsic muscles. And the release of the intrinsic muscles has been done classically by removing a triangular of the extensor hood. This is the sagittal band. Here proximally are the intrinsic muscles, and this is the tendon, but it's not necessary to do this. It's too much of a surgery, and preferably I do a transverse incision on the base of the finger. This is proximal, this is distal, this is the web of the finger, and this is a man, obviously, because of the hair. The transverse incision, you move the skin towards one side until you see the extensor hood, and then you keep cutting the extensor hood from volar to dorsal. You can cut it completely up to the extensor tendon in very severe cases, holding the MP joint in extension, while with the other finger we flex the PAP joint, and we'll see that the PAP joint can be flexed even keeping the MP joint in extension, because we have cut the extensor tendon more or less from here to here to here or to here, depending on the amount of muscle retraction. Stage 3 is when there is a fixed or stiff PAP joint. The underlying pathology is all the things that we said before, plus shortening of the dorsal structures, which is the extensor apparatus, central slip and lateral bands, dorsal capsule, and skin. These are the dorsal structures that will prevent flexion of the PAP joint. And the treatment, when there is a PAP joint fixed and extension, is manipulation into flexion of the PAP joint. You don't need to do surgery. Release of short and intrinsic muscles, then you have to release them because you cannot elongate them by manipulation. Release of flexor tendon adhesions. You can do it by making a small incision proximal to the pulley and pulling the flexor tendons until you release all the adhesions. And if needed, you can do a PAP joint tenodesis with half of the sublimis, as I have shown before. And finally, the stage 4. The PAP joint is not only fixed in extension, but it's destroyed. And here we have to make the diagnosis with a radiographic examination, because the joint is fixed and we don't know if it's because of capsular stiffness or because of joint destruction, like here, small finger and middle finger. And the index finger and ring finger, they are more or less spared. What is the treatment in stage 4? Same as before, plus a PAP joint implant arthroplasty. Here we have this case with a destruction of the PAP joint of the small finger here, the middle finger also, and here we can see it in the x-rays. In the other ones, the joint seems to be more well preserved. If the joint is not destroyed, we can just do a manipulation into flexion. And you can do it in the office if you want with a digital block anesthesia, just to be sure yourself or show the patient that you don't need surgery, but you have to do it slowly, very slowly, and you will see that the joint will flex. You don't need to do a surgical release, like many doctors that they do a C-plasty lengthening of the central slip, which is not shortened, or you can or cut this fibrous tissue, connective tissue that connects the central slip and the lateral bands. And by flexion, by manipulation, usually you can flex the finger. In the fingers in which the joint is destroyed, there is no other choice than place an implant. This is a dorsal view with the implant. This is a flap of the extensor tendon. I use a long flap to allow early mobility of the implant arthroplasty. But in all of them, you have to do release of adhesions by traction, at least, of the sublimis. Here you can see flexes the PAP joint, a little bit the DAP joint, because there are adhesions between the sublimis and profundos. And here, by pulling into the profundos, we can see that we can gain flexion of the DAP joint. And this is the incision that we used for placing the joint implant. Before closing, we should check the integrity of the tendon and skin sutures after passive flexion of the joint. Should check that the extensor tendon doesn't rupture with flexion, so that it has not remodeled in a shortened position. And then we should check that the skin, more or less, it's relatively, here it's a little bit tight, but we can flex it after surgery. And after surgery, this is the middle finger, and this is the small finger, in where we have placed implants, and you can see that the patient can have a good flexion of the finger after implants. The reason is that, I'm sorry, we'll go to the previous one. The reason that there is a good, the swan neck deformities that you can put an implant is because the extensor apparatus is intact. This is very important. To reconstruct the extensor apparatus, like in a boutonniere deformity, is very difficult. A flexor tendon can be reconstructed in a two-stage procedure, because it's just like a rope. It's a cord, but the extensor apparatus is very complicated to reconstruct it surgically. And then we have finally, because nobody talks about, the flexion deformity of the MP joint. If you don't correct this, you will get a recurrence of the swan neck deformity. Because if you recall all the pictures that I have shown before, I mentioned that there is a flexion deformity of the MP joint. And this should be corrected. And can be corrected, should be corrected, well, by division of the insertions of the intrinsic muscles to the extensor, and sometimes even into the bone, to the proximal phalange. Sometimes there are adhesions on the volar capsule, not because of tendon synovitis, but because of the patient might have some synovitis of the MP joint. In these cases, I do a complete transverse incision of the volar plate at the level of insertion into the proximal phalange, and I cut the insertion of the intrinsic muscles at that level. And then you should be able to extend the proximal phalange without any difficulties by cutting the intrinsic muscles and by cutting the volar capsule. But another problem is the skin shortening. The skin remodels in a shortened position, and you should always do a lengthening of the skin at the base of the finger. Here it's a patient after manipulation of swan neck deformity, in flexion, and here the surgical result after doing an intrinsic muscle release, a volar plate release right here. It should be more proximal phalange ends up here, in the skin Z-plasty lengthening at the base of the finger, because that's where you can get more length of the skin from the sides to gain in longitudinal. And this is the result. Also, I did a fusion of the PIP, of the DAP joints. If you remember, there was a very severe, well, let me see if I can go back. It was a very severe mallet finger. If you don't correct this, you will get a swan neck deformity again. So you should correct the mallet finger as well. And this is the result, which is quite functional, because it has good MP joints, because you release them, has practically full extension and full flexion of the PAP joints. And the only thing he lost is the flexion of the DAP joints. And the DAP joints should always be fused in full extension, not in flexion, in most of the cases, unless it is a boutonniere, to get a more balance between flexion of the PAP and the DAP joints. We're getting towards the end. Swan neck deformities are more disabling, like here, because the patient cannot hold practically anything, than boutonniere deformities. but they are easier to correct than I'm sorry, means boutonniere deformities instead of swan neck. So swan neck deformities are more disabling and easier to correct than boutonniere deformities like here. Boutonniere deformities, it's very difficult to correct, and it's more useful for the patient to have a finger like this than a finger like this. Sorry about this. This should say boutonniere right here. So as a resume, this is all the pathology that you can see in a swan neck deformity. All these all these alterations, and you should correct them, all of them. If you don't correct, if you correct them all, you will have a good result. But if you leave one without correction, a mallet finger, a flexion contracture, the MP joint, the structure of the PAP joint, or a flexotendon adhesions, you will not get a good result. But if you do all the things that they are listed here, you will always get an excellent result after correcting the swan neck deformity. And finally, very short, because it's quite late and you must be tired, and it's very simple to explain, the treatment of a mallet finger, like here. This is a mallet finger, quite severe. You can do extensor tendon application, but even in trauma cases with normal extensor tendons and no stiff joints like here, the results are very unpredictable. You can do then an implant arthroplasty or an arthrodesis. An implant arthroplasty, you should never do it, like in this case that was referred to me, with a dislocation of a silicone implant. And the best thing to do for a mallet finger deformity in a rheumatoid patient is a fusion. Thank you very much for your attention.